We're going to start into the system section, and we're going to do cardiovascular first. And everybody gets nervous about cardiovascular. They go, oh my gosh, congenital heart defects. But I don't want you to get really worried over, things that, because mainly it's going to be an assessment. I'm going to point out for you things that are going to be most prevalent in your assessment tools, kind of thinking about what would be helpful to you. The only thing I wanted to tell you is that you're not going to be asked to read EKGs. Thank you, right? Unless you are an EKG guru and you really enjoy that, right? But, so you're not going to be asked that per se, but I do want you to know that there are going to be things in the notes that I'm going to share with you that are reflective of either an EKG or maybe an echocardiogram or something like that, or an x-ray. So just so it'll be described to you. So let me get you started. And I can't overestimate how much it is an important point that you know how the blood flows through the heart. Make sense? So you guys are going to keep that in mind. I don't really need to go through that per se, each step and so forth, but it's important because when we talk about congenital heart defects, what's going to happen is there's going to be something that's going to disrupt the flow. Something's going to have a new opening, or it's going to be having the blood redirect because of pressures. So make sure that you are familiar with that. Everyone gets a question about S1, S2, one or the other. And so when you look at heart sounds at anatomical locations, think about S1 as mitral tricuspid valve closure, whereas S2 is your aortic pulmonic valve closure. The way I kind of think about S1 are your AV valves. That means between the atria and the ventricles, right? So these are between the atria and the ventricles. So S1, AV, A is the first letter of the alphabet. AV valves, which particularly relate to these. Y'all remember that with your anatomy and physiology. S3 is Kentucky, increased fluid states, and S4, Tennessee, stiff ventricular wall. In a very well-trained athlete, like a child that is like a track star or something like that, you might get an S4 that would be normal in that particular condition. But they're not going to ask you anything specifically, because most of the time an S4 means that it's really a stiff ventricular wall. We also know that aortic and pulmonic sounds, very important. Everybody gets this. This is a pink pig. Aortic is right upper sternal border, and pulmonic is going to be the left upper sternal border. And typically, where it's going to be is at the second intercostal space. So you think about where each one is going to be, and it pretty much from a definition perspective, they will ask one or the other. Very important information here. Let's talk about some of the characteristics, okay? This is going to be helpful to you as you go through and you think about how to look at congenital heart defects as a whole. We do know pretty much, or at least you should be familiar with, blood is going to flow from areas of high pressure to areas of low pressure. Doesn't that make sense? It's going to shunt away from where it's going to be high pressure. So let's talk a little bit about resistance and flow. And in your notes, it's pretty clear as you look here, fetal, as it says, increased pulmonary vascular resistance, PVR. And I'm looking at your notes because it's got a little bit more information in your manual. Decreased systemic vascular resistance, or SVR, because there's not going to be any blood flowing up to the lungs. So let's think about this. It's the opposite when you look at the neonate. And the neonate, you have decreased PVR but increased SVR because it's going to go up to the lungs. Maybe if you could kind of think about this. If, while in utero, you don't need blood to go up and get oxygen through the lungs, doesn't it make sense if the principle is high pressure to low pressure? So the high pressure is going to be the lung bed, which is PVR. PVR is going to be high because the systemic side is low. So it's like this. When you think about cutting the cord, and you need blood flow to go up to the lungs, it's going to drop, the pulmonary vascular is going to drop, and the systemic is going to go up, because the high pressure side, the systemic side, the left side of the heart, is going to force the blood up through the lungs to pick up oxygen. Doesn't that make sense to you? So it's a very clean transitional process. We also know that murmur loudness scale is when you perhaps have a murmur that's like a scale of 1. You pretty much have to do what? Listen with that stethoscope. But 6, you might even be able to hear it just merely by standing next to the neonate. What about a VSD? Why do you think that's up there? Well, VSD, as it notes in your manual, has often a thrill associated with it. So whenever you have a scenario where there's a thrill, you might want to think about maybe there's a VSD. And in a few moments, we're going to go through separate ones. And one of the ones that we know has a VSD, but has 4 defects, is Tetralogy of Fallot. So if you see that it has a thrill, that will give you an idea. What about your obstructive defects? Well, this is where you're going to get ejection clicks due to turbulence. That's the key. Blood is trying to do what? Force its way up through a more narrow pathway. It's going to be, because remember, little infants, the younger you are, the faster the heart rate, and so therefore it's going to be very rapidly trying to get through a very narrow area. Also, you probably will see referred or radiated sound also associated with these. Now, one thing that I don't have in these notes that I think is probably pretty key, especially if you are a family nurse practitioner where you're going to see children and adults, is almost all of your congenital, pediatric-oriented, newborn-oriented murmurs are systolic in nature. Okay, very rarely do we have a diastolic. There are a couple of unusual ones, but I want to say for the predominant ones that we need to think about from primary care would be systolic. So there you go, just kind of add that little piece to the side. And we also want to get into now looking at the different characteristics. Oops, I went the wrong way. Congenital heart defects, and we're going to go into each one individually, and I'm going to point out to you some pieces of information I think will help you to understand. But before we start, let's generically look at the etiology is really multifactorial, meaning that it may be a chromosomal abnormality plus something in the environment that may have caused this heart defect. The most common one is a VSD, 30% of all congenital heart defects. And you also want to see a cardiovascular malformations typically arise from those abnormal structural findings that we see. Do you all remember the different types, the different categories? We have acyanotic, cyanotic, and obstructive. Acyanotic really means without cyanosis. So when you think about acyanotic, that means that the blood's going to shunt from the left side. Do you all remember that left means system, predominant, that's the body, the rest of the body, system, and it's going to shunt over to the right, which is the pulmonary side, pick up a little oxygen from the lungs, maybe not a whole lot, but enough to sustain, and then it's going to go on and continue its cycle. Cyanotic lesions really do what? They bypass the lungs. So it's going to come from the lung side, shunt straight out to the system, and that's when you're going to get cyanosis associated with it. And then, of course, we're going to talk about obstructive lesions. So let's start off first with a couple of examples for acyanotic. The acyanotic, and before I even go into this first one, can I just mention to you, there are some cyanotic conditions that are not compatible with life unless they make an acyanotic lesion. Does that make sense? Unless they go in and make what we call, it needs to be, it's septum dependent. So they got to go in and make an opening so they get a little bit of blood flowing in the right direction to pick up oxygen. So when we think about an ASD, and I know you're thinking, gosh, am I going to need to memorize all the different grades of murmurs and all? I actually been very successful with practicing and passing these exams without memorizing what type of grade, because it varies. You can look at, it's a grade 2 to 3 on a scale of 6. But we do know that most of them are systolic, so I would key into systole. I would also key into where do you hear the murmur? Well, with an atrial septal defect, which means between the two atria, which are higher, you're probably going to hear in the upper sternal border, and it's going to be on the left side, is where you're going to predominantly hear this murmur. The murmur is going to be reflective of that which you would see on an EKG where you have hypertrophy. Now let's think about this. What I want you to take away with each one of these is where is the murmur and predominantly what type of hypertrophy is there that's present. What does that mean? That means that the blood and the pressure that's involved in its flow is going to either make one side or the other ventricle probably more prominent or more heavy, more full. So what's going to happen here is the right side is going to be more evident. And I told you, you don't have to read an EKG, but just know that right ventricular hypertrophy, even if it's reported. Most of the time, most of us see LVH, right, with a lot of the conditions, but this particular one has right. X-ray. This is real common, almost every type of congenital heart defect. Cardiomegaly with increased PVMs, pulmonary vascular markings. That's real classic for just about any of those that are going to be a heart defect. Here is the most common one, VSD. And you could pretty much think about it right in there. You could see the opening, and that means between the septum, you're going to have an opening, so blood is going to interchange. And it's going to be holosystolic. See that? Well, what does holosystolic mean? It means across all of systole. Systole is pretty fast in a newborn, right? Because it's very rapid heart rate. You're probably going to maybe even feel a thrill. You notice it says felt at the left lower sternal border. And the reason it's lower is because the ventricles are lower. You also want to think about the pressures. Well, typically the left side is going to end up with hypertrophy as well as your cardiomegaly and your increased markings. When I think about this, one other thought I want to have for you is let's talk about the size of the opening. And this makes kind of sense. A lot of the size, if you have a very tiny opening, say this ventricle space in here was maybe cut in half. So if it was half of that space and blood was trying to rapidly get through that, you probably will hear a louder murmur because the turbulence are trying to get through. The wider the space, the more opening it has, the lower the sound. Does that make sense to you? Now, we also talked earlier when we did Down syndrome. I mentioned to you you could have ASD or VSD, or you could have both, A and VSD. So the entire septum can be open. Now, the PDA, many of you have these smartphones, right? We call it's like a little machine, and so I think about a PDA being having a machinery type of sound. It's holosystolic. Your left side is going to be hypertrophy to maybe even both biventricular. So you may see both of them. X-ray findings, cardiomegaly, increased pulmonary markings. Now, when we think about this, see how high it is? The ductus arteriosus. Is it not open in utero? Absolutely. When does it close? Does anybody remember? Usually it can close anywhere from about 48 hours to maybe even a couple of weeks. Sometimes we try to stall it. If you have a child that has a cyanotic condition, heart defect, and they are dependent on getting a little bit of oxygen up to the lung bed, they're going to try and maintain that open. What will help maintain it open? What do you think about? What can help to, what helps to close it? What about prostaglandins? Remember prostaglandins? Prostaglandins. So sometimes we will stall its closure just to kind of keep that open. All right, so let's move now to cyanotic lesions. And this is where you have that right side shunting away from the lungs out into the system, so you're going to have less of your, you're going to have more cyanosis and less oxygen availability. Here's an interesting one, transposition of the great arteries. So this means that there's a murmur same as a VSD. And what is the murmur of a VSD? Holosystolic, right? And it's going to be in the left lower sternal border. EKG finding RVH, and they typically show what's called an egg on a string on the X-ray. Now, this occurs over time. What that means is, if you have, and let's think about this, what happens is, do you notice that typically your pulmonary artery comes off your right ventricle, whereas the aorta comes off the left ventricle? So about the same time that in a normal baby that the patent ductus arteriosus would normally close, remember we said 48 hours to 2 weeks is normal closure period, that's about the time that you have the swapping of the two major vessels off of the two areas where they actually serve. So look at this. Isn't this a crazy thing? Aorta coming off the right side. So guess what? If this is a cyanotic lesion and it goes from right to left, that aorta is just shifting it straight on out, just keeps going out into the system and making the baby be very cyanotic. Whereas there's very little coming in from the left up into the lungs. When this happens, this heart, the ventricles eventually get very heavy and very full, hypertrophic, okay? And so it looks like an egg on a string. It's kind of hard to describe, but it gets very narrow here and gets very enlarged like that. And that's why they call it. But you know what? That's going to take a while for that to happen. It doesn't happen right away. It takes a little while for that to occur. Now, if I were a testine writer, I would definitely ask you questions about Tetralogy of Fallot, because this is one that has several that are very common. 4 defects. You're going to have a VSD, which is right in there, the ventricle septal defect. You're going to have a pulmonary stenosis. See how narrow the pulmonary artery is? Hard to get blood up through that area. You have an overriding aorta sitting right over there, and right side will be hypertrophied. Isn't that interesting? And so you got 4 defects. It's a systolic ejection murmur. Why do you think it's got an ejection click or an ejection murmur? Anything that's stenotic or narrowed, obstructive, like a PA, pulmonary artery stenosis, is going to have, because the blood's trying to rush through that, and it's going to make that sound. And so therefore, that's going to be really key. I tell you, pink pig, this is one that you really need to know, because this is one that they can economize by asking you about the VSD. What else would you have with this one that's not up there? You might want to write in the margin, a thrill, right? Wouldn't you have a thrill and you'd have that ejection click? Perfect. Now, you also want to think about where you're going to have your hypertrophy. Well, right ventricular hypertrophy and a boot-shaped leg. Have you ever heard of that, the boot-shaped heart? What that means is if you're having this right side get pretty full, it's going to kick the heart out. It's going to look like a boot eventually over time. These are the kids that have the old, remember the TET spells? What's a TET spell? A TET spell is a hypercyanotic spell episode. The child can even pass out with this. These are kids that get very short of breath, very hypoxic. What do? They squat. When they squat, they slow down the return of blood to the heart. That's going to cause what? The right ventricular hypertrophy, okay? So you see how that kind of works out. These are also the kids that may have periorbital edema. They may also sleep in a knee-chest position. Obstructive lesions. Well, here you got the aortic stenosis, and this is where you have a systolic thrill. So you're going to get, now let's think about this. Your obstructive lesions are going to have ejection clicks and maybe even a thrill. It's going to be dynamic, lots of turbulence. And it's going to be in the right upper sternal border, and an ejection click is going to be noted. And they're typically going to have left ventricle hypertrophy. X-ray, well, usually it's normal, but if it's real severe, you might see signs of congestive heart failure, which would be, what? Cardiomegaly and increased pulmonary markings. What about pulmonary stenosis? It's kind of hard to see right in here, but it involves the valve. And the valve is stenotic, so it does what? It is narrowed, and blood cannot get through there. So what you're going to have is an ejection click, a thrill. It's going to be in the left upper sternal border, and the findings are going to be such that, but where does the pulmonary artery come off of? The right ventricle. Guess what? If you got a narrowing there and it's going to be backed up, what's going to back up into? The right ventricle. Doesn't that make sense to you? So it's going to be everything that's pre that narrowing is going to be more full. And then probably the one that they classically like to ask you more about, because wouldn't you know, if I asked you questions about Tetralogy of Fallot, which has pulmonic stenosis, I took care of that. And then the next one probably would be coarctation. That would be one you would think about. Coarctation is one that you have an ejection murmur, radiation to the left interscapular area. It's in the right upper sternal border. And you're going to find, eventually, first we start off with the right side hypertrophied, then it's going to end up involving the left. And we want to think about some of your x-ray findings. Well, yes, you probably will see cardiomegaly, pulmonary venous congestion, and have you ever heard of rib notching? You know what that is? Well, let's think about this. If you have a notched or narrowed area, see how the aorta goes along this area? And it's narrowed, but you got pretty high pressure there. What's going to happen is the body is wonderfully compensatory, and it's going to build its own collateral circulation around it. And when it does, it's going to have all these extra vessels around in the upper area where your ribs are. So it's going to appear that the ribs are notched, but it's collateral circulation. Blood pressure, pulses, I know it says up here BPs, but also if you did pulse ox, you checked your pulses as well as your blood pressure, you're going to probably see some discrepancies between the upper and lower extremities, okay? Now, as a little reminder to you, remember earlier today when we did genetics, I told you all how important it was to think about genetic conditions having seizure, neurological, and probably cardiac conditions. Let's just review for a minute. DiGeorge has aortic arch anomalies. Your trisomies have usually your septal defects and predominantly VSD. Marfan has aortic regurgitation, mitral valve prolapse. That's the one that leads to an aneurysm. And Turner syndrome typically has that coarctation or tricuspid aortic valve. So there you go, just as a little reminder. And we know how important it is to do a good assessment, such as prenatal birth family history. If you have a child with frequent respiratory infection, exercise intolerance, they get so short of breath and dyspneic. A baby that can't feed and, nurse feed at the same time gets diaphoretic. Tachypnic, those will be some considerations. And so thank goodness in our primary care exam, you're going to refer them. If you take the pediatric acute care exam, you better strap in. You're going to be reading EKGs and doing things with all the different procedures. But for here, mainly they emphasize the assessment, and you're going to refer to cardiology. Part of your role is to maintain optimal care, as you would imagine in primary care. Let's take a moment and look at innocent murmurs. Innocent murmurs are found in childhood, do not signify pathology. No associated symptoms or failure to thrive, functional, benign, physiological, occurs in more than 50% of kids. Routine testing is not indicated. But I will tell you this. You can have a child that has both a pathological murmur and a functional murmur. And so trying to tease those out, would probably have to be left up to the cardiologist because they would have that ability to do that. But let's think about what are some of the general characteristics. Well, innocent murmurs as overall, as in general, are best heard in children because they have a very thin chest wall, more angulated vessels, and more dynamic circulation. When I see this, you know what I like to think about? And you can write this in the margin. Turbulence. Doesn't that make sense? If you have, think about this. That's one of the reasons why, and we haven't done ears yet, but remember how when you do ears, you look at ears, you pull the ear back, for children under 3, back and down because the eustachian tube's highly angulated? Well, guess what? Their great vessels are highly angulated. The more angled, if you have a ventricle and you have a highly angulated aorta, you're going to have a lot of blood trying to get through a high angle. It's going to make turbulence. So that's what the whole idea is. It's nothing magical about it. I will tell you, they are always systolic, so you're going to always hear them on systole. So I would write that to the side, systole, typical characteristic. Low intensity, or you can either highlight systole, may vary with position. Sitting to standing can change the position and the sound, but there's no radiation to back or to the neck area, okay? And we want to go through, I'm going to give you, actually there's quite a few functional murmurs. And we used to present all of them, but we thought, you know what, they're not going to test you on all of them. But let's look at 2. One is Still's murmur. Still's is the most common. It's a musical murmur. Heard best in the left lower sternal border. Guess how I remember this? LL, left lower, okay? Sternal border in the apex. It's due to turbulence in the left ventricle outflow tract. What in the world is that? That has to do with the left ventricle and the aorta. Turbulence is right there. Left ventricle outflow tract, right where the aorta comes into contact. It is a systolic ejection murmur. Do you all remember the venous hum? This is another very classic one. Continuous humming murmur right upper sternal border. Heard best while sitting. And when you think about when you sit, but then when you actually can obliterate it by turning the head and or compressing the neck on the, what's ipsilateral? You know, a lot of times you may not know that particular, but think about its opposite is contralateral, means opposite side, so ipsilateral is the same side that you hear the sound on. So just by compressing the neck, you can actually obliterate that sound. Y'all ready to move out of congenital heart defects and go into acquired? Let's go and take a look at this. What do you think we're going to start off with? Good old hypertension, right? Oh, and you know one thing I wanted to tell you, on your notes, if you would take a note there where it said, with venous hum, if you'll see number 3, it said heard best in sitting position, but disappears in the supine. So remember we talked about positional changes, so make sure that you know that that is taking place, okay? Now, acquired heart disease, hypertension. Hypertension is hypertension, and no matter what your age is. It means the same thing, more than 95th percentile per, is actually per an individual based on age and sex. And I just happened to mention to you earlier today, and now we're seeing again, that we use tables. And we use tables to get to the child by age and sex. And we do it on 3 separate occasions. Hypertension is a symptom of organ dysfunctions, the most common in children. This is very important to think about, because you were thinking, well, how is it different than with adults? Most adults start out with hypertension as a benign essential hypertension, not associated, it's primary, right? Children don't start out with primary hypertension. We usually see hypertension in kids because of a problem with an organ, kidneys, okay, renal vascular, some type of aldosterone problem. So does that make sense to you? So that's a big difference. We also know, we pretty much know the symptoms: headaches, visual problems, dizziness, respiratory distress, irritability, and nosebleed, but not all kids can tell you this, right? Because a lot of them are pre-verbal. We think about what needs to be worked up. Well, anybody with hypertension probably needs a whole host of lab and diagnostics: x-rays, plasma aldosterone levels, checking for Cushing, cortisol levels. And by the way, do you all realize that cortisol levels are best checked first thing in the morning? That's when they're highest. And they're lowest at night, so they're diurnal. So I just wanted you to know if you're testing it needs to be early morning. UA base, and then like you're going to do your BMP, CBCs, EKGs, but we're not going to read them per se for the test, but you're looking for, you know, if there's any type of hypertrophy or some type of blockage. And what are we going to do with these kids? We're going to refer them to cardiology. They're going to start them, and guess what they do? They still do the same thing. They follow JNC 7 guidelines. I understand that JNC 8 guidelines, by the way, are hopefully going to be out in December, is what we're hearing, new guidelines. So, but we do see that children do fall under that, so the cardiologist will also follow with that. Now let's do rheumatic fever heart disease. This is a classic pediatric condition. It's a post-infectious inflammatory disease affecting the heart, joints, and CNS. Rheumatic heart disease usually follows, it's post-infectious after a group A streptococcal infection. Usually the valve that's affected is the mitral valve. So guess what? Anytime you would do what? An echocardiogram, you're going to always see that the mitral valve has been affected. It's never going to go away. It's a permanent effect. Tell me how many of you have heard of Jones criteria? Okay, just a couple of you, okay? A couple of you have. Jones criteria is a classic set of criteria that we use to kind of put our arms around the symptoms that are associated with it. And it says here 2 major or one major and 2 minor. The major criteria that you see here: carditis, polyarthritis, chorea. Remember, chorea is that slow worm-like movement. Erythema marginatum. I'm going to show you a picture with some of the rashes and then some nodules. Now, the minor criteria could be arthralgias, fever, your acute phase reactants, which would be something like your ESR being elevated, your CRP being noted, as well as maybe strep cultures and things like that can include in that. And can I tell you, even though I said you're not going to have to read an EKG, here we go with the pink pig. Classic for, very, very classic, is prolonged PR interval on an EKG evidence of any group A beta hemolytic streptococcal infection that affects the heart. You're going to always see that. Very, very classic. So put a little pink pig, a little highlight, a little whatever you want to put on your notes. We also think about the rash, erythema marginatum. This is not the strawberry tongue, but it's an area, you can see here, I love that word, confluence, kind of runs together. And you can see the rash area here. And these are just kind of reminding you of where basically some of the symptoms that we talked about in the criteria. There's some more of your acute phase reactants like a positive culture, rapid strep culture, or maybe even a rising antibody titer, EKG and echocardiogram. And again, the echocardiogram is going to reflect mitral valve. What are we going to do with these kids? They need to be referred to cardiology, pediatric cardiology, aggressive management, making sure that strep infection is cleared up, carditis, and also prophylactic antibiotics for any invasive procedure like a dental procedure or surgery. Kawasaki's. Now, Kawasaki is an acute febrile syndrome causing vasculitis. So when we think about rheumatic fever versus Kawasaki, rheumatic is post-infectious. This one is hot. This is a toxic vasculitis. Most common in children under the age of 2 and more commonly noted in Asian children. These kids are sick. They have a fever, and fever can be rather several days. You know, if you have a child that has a fever 5 days or more, that's for great concern. Plus 4 criteria, and you see here the conjunctiva or injected, a rash, the lips, you may even have some changes in the extremities where they get swelling, peeling of their skin. Strawberry tongue, look at that, okay? See the rash, the hand. This is all, look, it's a vascular, it's very hot, very toxic. But CBC, sed rate, your CRP will be noted, and there you go. You got your EKG changes again, prolonged PR or QT interval. So what are we going to do with these kids? Well, they're going to be the kid that's going to walk in your practice, and you're going to note it right off because you're going to see that strawberry tongue. You're going to see how sick they are. They need to be referred over to pediatric cardiology. And I just want to tell you, these kids, this is the one time that we are going to put kids on aspirin. We normally don't use aspirin with children, but high-dose aspirin, 80 to 100 milligrams per day for, until they're afebrile for 48 hours. Then you drop them down to a much lower rate for the antiplatelet response, and then the discontinuation of aspirin will be done in collaboration with your cardiologist, okay? So I just want you to know that information. That's been a pink pig on the exam, and actually, so make sure that you kind of are familiar with that. And I know that's not very funny, but the end. There we go. So there we are. Mostly, would you say most of it was an assessment? Pretty much, okay? So you kind of see where I hit. I highlighted certain things for you.